Hi, everybody, and welcome to the Family Matters interview series. Thank you so much for choosing to join the presentation tonight, and we are very happy to have you here with us. Just a few reminders that all of the lines will be muted throughout tonight's presentation. So if anybody has a question, you can go ahead and enter it into the chat box, and a member of the BCAT team will respond to you via email within 2 to 3 business days. We are pleased to have Dr. Andy Lazarus joining us this evening to discuss the happiness factor, a physician's perspective on focusing on quality of life for persons with dementia. Dr. Lazarus is a physician board certified in internal medicine. He has practiced both primary care internal medicine and geriatrics for the past 25 years. An expert in the management of chronic illness, Dr. Lazarus has extensive medical experience in office practice, long-term care, hospital care, prevention, and in multiple office procedures. In addition to internal medicine board certification, he has a certified medical director degree and is the director of several long-term care facilities in Howard County and beyond. Dr. Lazarus is a graduate of Brown University. He received a full merit scholarship to Albert Einstein College of Medicine in New York and completed his internal medicine training at University of Virginia Hospital. He has written 2 recent books on medical care, Curing Medicine and Interpreting Health Risks and Benefits, a practical guide to facilitate doctor-patient communication, and is often published in newspapers. He also speaks frequently in Howard and Anne Arundel counties about geriatric issues. Joining Dr. Lazarus is Lynn Young, the Vice President of Operations at Mansbach Health Tools. So at this time, Lynn and Dr. Lazarus, I will turn it over to you.
Hi, everybody. Welcome to today's Family Matters interview. Today, we are joined by our expert, Dr. Andy Lazarus. Welcome, Dr. Lazarus.
Hi, it's great to be here.
Thank you so much for taking the time to join. We're excited to have you. So I know, Dr. Lazarus, you are very busy, so I want to jump right in. Before we start talking about our topic of the day, I thought it might be helpful for our families to get to know you a little bit. Can you share with our audience a little about your clinical background, your professional experience working with older adults, kind of what you do day to day?
Sure. I've been a doctor for about 30 years, and I started off as internal medicine, and I gradually evolved to having a geriatric practice. For the last 13 years, I've had my own geriatric practice, myself and now 8 nurse practitioners. I'm always reluctant to work with doctors for reasons of knowing them too well. And I've written a lot of books on healthcare. I have a blog, a website. I've written fiction and nonfiction. I'm very outspoken about the fact that our healthcare system is driven mostly by people who want to make money and who want to basically treat you like a bunch of numbers and not like a human being. So that's been the crusade of my life. And in my own practice, we deal both with an outpatient group of older people, and also we go into mostly assisted living facilities and retirement communities and see people there. So the whole spectrum of the elder population.
You're busy. You're kind of everywhere. I know, serving as, that board certified geriatrician and seeing folks across the spectrum, as you mentioned, living in a multitude of settings, I imagine you see people who are, managing multiple types of health conditions, some of which might be chronic or progressive, like dementia. Can you share a little bit about your philosophy on how older adults and their family members can really embrace those older years instead of solely focusing on, the diagnosis or the illness or the symptoms that they're experiencing?
Sure. I read a book by a man named Norton Hadler about aging, and he calls the concept of medicalization of aging as one of the most dangerous things that we could experience. The problem is that a lot of doctors prey on elder people, pharmaceutical companies do, because they have a lot of things wrong with them. So why not fix everything that's wrong? So if we did CAT scans and tests on every older person we saw, we would just see cancers and blockages and everything possibly wrong. And if we fixed all those things, we'd probably not only cause them to be miserable, but we'd probably kill them. And the interesting thing about the geriatric literature is it really demonstrates that the less we do, the better. You know, certain interesting things. Half of cholesterol medicines are given to people over 80. That's half the population of people get them. We have clear evidence that cholesterol medicines don't work for people over 80. And yet the doctors are giving most of them to those people. We also know that the higher the cholesterol is over 80, the longer you're going to live. So yet we focus on that number, right? And people are obsessed with it. They want me to check it. Their families want me to check it. They want me to fix it. Cardiologists are infamous for just treating, you know, older people like they're 20 years old and stress tests and opening arteries. Well, they got blocked arteries everywhere. So my advice is don't look. Don't look for problems. The basic philosophy of geriatric care is if something bothers you, we will address it. If it doesn't bother you, we're not going to fish for it, because we're going to find something if we fish for it. And most likely it has nothing to do with anything that's bothering you. And when we fix it, you're going to be that much worse. The more medicines we have you on, the more tests we put you through, the more procedures, the worse you'll be. So my advice to families is just get off that medicine train, that medicalization train, and just worry about quality of life. Because it turns out that when we focus on quality of life, people live longer. We call it the hospice effect. Often when people go in hospice, they get better because they were just so tampered with by their family and doctors wanting to fix everything. And you just can't do it. So getting older should be really a focus on quality. And guess what? That leads to longer life too. So it's all good.
Well, I'm just curious, what are the family's reactions to that mindset? Because I know, like, as you mentioned, they often want the quick fix. They want a prescription or they want something to do about it. How do you find families respond when you sort of give them that feedback? Like, we're not going to, you know, look further. We've addressed this symptom and we're happy with that. So we're moving on. Kind of feedback do you get?
I'll give you an example. One of my pet peeves after I've written chapters on this and articles and done all the research is classic medicines we use to treat dementia, like Aricept and Exelon and Namenda, don't work. When they're measured against placebo, they work the same as placebo for up to a year. And magically, every pharmaceutical company stops the study at a year. And at that point, placebo is looking better than these drugs. So every other country in the world, other than ours, doesn't use these drugs. But our neurologists are in love with these drugs and prescribe them to a tune of about $6 billion a year. So when I explain this to families, I get one of two reactions. 90% of my family say, you know what, we never thought that stuff worked. Get rid of it. The second one is, who are you to question a neurologist? So they're an expert. Just leave them on it. I also get, I'll tell you a funny story. I call it the reverse placebo effect, because these drugs do have placebo effect. And so we have to account for that. So often when I take people off these drugs, the families notice that there have been some decline after when we take them off. So there was one family who we had them on Namenda. This family member wanted us to stop it because it was getting too expensive. And so we stopped the medicine, and a month later I checked in with the family member and he said, look, you know, mom's gotten a lot worse off the Namenda. I talked to my sisters. They think she's gotten worse. We really should put her back on. I talked to the aides who took care of her. They didn't see any difference. So I talked to the nurse, and the nurse said, I got news for you. The son told me to finish up the supply of Namenda. She's still on the Namenda. So that's what we call the reverse placebo effect. And unfortunately, people are influenced by what happens is people focus more once the drug is stopped on every little thing that they never noticed before. So then they see the decline. So yeah, I try to explain it as best I can through the science. Why they don't need cholesterol medicines, why they should stop seeing their cardiologist, why they shouldn't be on these drugs. Most people are good with, I think most people have common sense and realize that this is the way they always wanted to go, but the doctors were pushing them down a train of over medicalization. So yeah, the ones that push back, we just keep them on the drugs. You know, there's nothing we can do.
Right. That makes sense. Interesting. So you mentioned dementia, And I know that can be a really long, difficult sort of journey for family members and caregivers who are taking care of these folks day in and day out, maybe still in the home setting. Certainly, it has its challenges in managing that disease course. What are some of the, if medication isn't quite the answer, what are some of the other situational suggestions or strategies that you've shared with family members to help them sort of navigate that landscape of managing and taking care of somebody at home? What are the things that come up often, and kind of what are your suggestions?
I mean, one of the things in terms of medication is to eliminate as many as possible, to eliminate trips to doctors, to eliminate tests, because that irritates people with dementia. And one of the biggest things we need to do is not irritate people with dementia. So to that line, we also don't want to cross them. You know, if someone with dementia says that an alien spaceship just landed outside, then an alien spaceship has landed outside. In their mind, that's what's happened. And for you to tell them not is going to be insane. If they think their mother's still alive and coming to bring them home, then their mother's still alive. So I think we have to accept that their brain is working differently, but to them that is completely normal. So the goal is to make them as comfortable as possible that way, to make sure that they still believe they are not crazy, which they're not. You know, their brain is just now operating differently, and we have to go with everything they say up to the point that we can. You know, sometimes it gets too far where they just want to go and drive a car.
Sure.
Obviously, can't do that. We also want to give them as much autonomy as possible. One of the worst things with people with dementia is they're feeling that everything has been taken away from them. So the more we can give them, the more we can let them make decisions, or at least think they're making the decisions, the better. We never want to tell them like, Mom, shut up, you don't know what you're talking about, which I hear in my office far too often. Or, you know, Mom, let me tell the doctor this, you're really confused. That has a terrible effect on someone with dementia. So we want to let them talk, let them be in charge, give them as much as they can, never counter them unless it's a matter of safety, and keep them away from doctors. I always say the 3 ingredients to good health, and this is especially true with dementia, is a good diet. So even with dementia, eating a high fruit diet and a low sugar diet is extremely helpful. Exercise is extremely helpful. Keep them moving, walking, any kind of exercise. And the 3rd ingredient to good health is don't go to a doctor. So if you follow those 3 things, I think you'll do well. The medical system is just designed to subvert everything I just told you about. So the more specialist neurologists you see now, what you guys do, especially counseling, talking, helping that way, because the counselors I know are extremely able to listen, and not just going to give their opinion and talk. So that helps a lot too, because they're with someone who could actually listen to them and is not going to contradict what they say. So that's a good mix of things to do.
So can you speak to some examples of, it's tough for families to know when to intervene and kind of when to put the brakes on, like you said, depends on safety. It depends on, you know, their independence level, all of those factors. What might be some appropriate responses someone could say if, you know, their loved one is saying something that doesn't necessarily make sense or doesn't align with reality? What do you suggest? What are some ways that they can respond to that without being confrontational or increasing their agitation? If someone said, what should I say in that moment? What could they do?
It's something not a safety issue. I had an aide once who, I put this in one of my books, who the person wouldn't ever take a shower. So the aide said it was prom night, and shower, and every night became prom night, and that's how she took a shower. So the aide was lying, but that's what you have to do. You have to lie, and that's how you deal with it. So if someone says my mom's coming and she's really mad at me and I'm really afraid, you say, yeah, but she just called up and said she's distracted. She had to go to the store, so she's actually not going to come today. She's going to come tomorrow. You know, you don't say your mom's dead. That's just not what you say, because in their brain, it's not. If it's a situation with a car, you just say it's being repaired. We're going to get it back soon. The license got revoked, and we just have to but we're taking care of it. So don't worry. It's not like, and you can never drive again. It's just
Right.
what you don't want to say. So there's always a walk around almost everything. If people are unsafe in the kitchen, you remove all the knobs from the stove and the oven, and you just tell them they're being cleaned, and we'll let you know when. So again, it's not like you can't cook. It's just right now the situation's not letting you do it, but you'll do it later. So by later, you could do the same thing again. So it is just a matter of lying with them in a way that they're comfortable with. And it takes really, some of the nursing aides I work with who are young have got this figured out. I mean, they're so good at it. Some other people are just terrible at it. They just can't do it. They get angry. So once you show anger, that's not good. So you just, even if I've walked around with older people and got hit constantly, and I'm just still laughing and smiling and talking to them, and then the hitting goes away. It's just, once you say stop hitting me, the hitting's going to get worse. So just being non-confrontational has been my approach. I think it's worked pretty well.
That's a really great point, is what the person who's interacting with the older adult brings to the interaction. So we may not be able to change what they're saying or how they see the world, but we can kind of control how we react, or, our facial expression, our body language, our tone of voice. Those are things I don't think people always think of, that they contribute to, the situation, the success or the failure of the situation.
Absolutely. And it's very, very hard for the caregiver. It's very hard. I saw a patient today who is just devastated because he goes to visit his wife in a nursing home, and the wife really could care less who he is. And he's changed his whole life to make sure she got there. He moved out of independent living to be close to her, and she doesn't care. And in fact, I've seen many people come get new boyfriends or girlfriends, and when their spouse comes, they say, "Oh, mom's coming, we better be careful." So that's tough for people. But you got to go with the flow of what's going through their minds, and that's all you can do.
Yeah, that's got to be really tough for a long-term, married partner to hear that from someone. That's really rough. I know that sometimes these, older adults end up in the hospital, and that has its own set of issues and concerns, whether they're dealing with a medical issue, there's testing. It can be very disorienting. They can, families often report they seem different after their hospital stay, or they're more agitated or upset. How do families balance the need for maybe an ER visit with what may be, lasting effects from being in the hospital? I know that's a challenge people face. What are your thoughts on that?
I mean, first of all, the hospital should be the last resort. We know there's virtually no illness other than something catastrophic, such as a burst appendix, where the hospital is going to give you a better outcome than not going to the hospital. We know your chance of dying in the hospital from just being in the hospital, not from anything to do with your illness, is 1 out of 300, just for going to the hospital.
Well, that's an alarming statistic.
You'll be killed by the hospital is 1 out of 300 chance. So, and the chance of them helping you in a way that we can't do on the outside is minimal. Again, unless you're dealing with something catastrophic. So yes, you're right. People leave the hospital in worse shape than when they came in, when they have dementia. They're more agitated, they're more confused, they may never recover, they're weaker. They were put in a bed, they had a urinary catheter put in, they were down. There are no rules in the hospital. So it is a barbaric place. The primary care doctors are not allowed in there. They don't talk to us. So you get a new set of doctors. They make their money by sending you to as many specialists and as many tests as possible. So then you come out of there thinking you're sick, and the family thinks they're sick and about to die. And they've been sold a bill of goods that had they not come, they would have died, which is a bunch of nonsense. So anytime you could communicate with your primary care person before you make that decision, it'd be a good idea. We do send people to the hospital, mostly for catastrophic things, but we can usually tell when that is, and we like to be involved, but it's been harder and harder lately for our primary care doctors to be involved at all, which is what makes the hospital experience that much worse. So yeah, be frightened of the hospital. Go under as a last resort. And when you're there, insist that the hospitalist discuss everything with the primary care doctor. Insist on it. It's your right, and they won't do it otherwise. So you could, and also insist on talking to the hospitalist every day, because they will do things that shock you. And you got to put your foot down and tell them, I don't want them to see these 12 doctors or get these tests. She came in for confusion and you said there's pneumonia, we're done. But it won't be that way unless you're on top of it. And if you can get the primary care doctor involved, that's all the better. And they will, if you insist, they will call.
That's a really good tip. I think in general, people are intimidated, right? In a hospital setting, they assume the doctor knows best. This is their, expertise. Who am I to challenge their decisions? So I think that's a great step to empower families to be sort of on the lookout for some of these things. What are those questions to pose? What kinds of things can you ask for? And what's realistic and reasonable, on behalf of your loved one, to kind of advocate for them.
You have to. If you don't advocate, they're going to take the path of least resistance. So, and that is just to do a lot of stuff and ignore the basic things. Like they might order 4 scans in a day, and because of that, the person didn't eat. And that's just not a concern of theirs. That's off their list. So yeah, you have to advocate. And again, the best way to do it is just to be in communication with them on a regular basis, and don't be intimidated. Some of them will, like me, I communicate by email, which makes things easy. Some of them do, some of them don't. If you do email, the beautiful thing about that is then you could take that email and send it to the primary care, and then the communication just gets expanded. So it is much better that way. But some doctors are still not able to do that. Don't ask me why. Because I think email is much better, because it again allows communication to occur, and it's documented and it can be passed to other people. But regardless, how they have to answer you. So don't be intimidated by them. They don't know your mom or dad. They don't pretend they're going to ever know them. And they're just doing stuff, and they're not experts. So don't ever think they are.
That's a really good point as well. Is your primary care physician knows you. They know your story, your history, the ups and downs of your health, what's been tried, what didn't work. They bring to that interaction all of that background knowledge. So it makes sense that it would be, advantageous to include them in the conversation, because they're already sort of up to date on everything that's been going on with your health.
You'd think they want to talk to us, right? You think that, but they just don't. Because we'll probably tell them not to do all those tests that they want to do, because we've done them already, right? So they don't want to hear that. So yeah, it's funny that you'd think they would immediately be on with us to find out what's going on, and that just doesn't happen.
So after, let's say, one of your patients leaves the hospital and checks in as a follow-up, do you then go back through what medications they were provided at the hospital and any follow-up appointments that are pending, and kind of taking a look at what they were told and versus, what you think is appropriate?
We stop almost every medicine that they were given. We stop almost every follow-up visit that they were told they have to do. And we explain what happened in the hospital, that really wasn't a urinary tract infection, that wasn't a TIA, which is the other big diagnosis they blame everything on. That's like a mini stroke. And we say what to do next time this happens. That's usually the case. Obviously, there are times when follow-ups are needed, like a broken bone or surgery. There are times when medicines are needed, like if they went in and had a heart attack or a seizure or something else. But most of the time, I swear to you, 90% of the time they claim it's a urinary tract infection or a TIA, where it wasn't either one of those, but they need to write something down, and they end up coming home. Another big thing is when you go to the hospital, your blood pressure goes up because you're in the hospital, right? So
it's just the stress of being in the hospital, right?
You probably on all these blood pressure medicines, and you come back and faint. So yeah, the hospital is we do immediately within 2 or 3 days we'll see them and go through everything and clear things up.
Okay, that's another good tip, I think, is if you did have to go into the hospital, definitely if they don't already help you set up a follow-up appointment, reach out on your own, reconnect with your primary care provider and at least touch base to make sure that what's in place is appropriate for your loved one, and make sure that you have everything organized in a way that makes sense for their health. Interesting. Okay. You've been a wealth of knowledge. This is really great information. I think families are really going to appreciate all of these. They're very practical tips. It's things you can do tomorrow, things to be on the lookout for, ways to interact with your loved one, your physician, the hospital system, if the case, arises where you need to advocate or ask questions. And this is really great info. I know we're almost out of time, but I did want to touch base. You mentioned that you've authored a lot of books, and I know sometimes, people are looking for other tools, other resources. Tell us a little bit about the books that you've written and, where folks could find access to those resources.
Two books that are probably the most useful. One is called Curing Medicare, which I wrote about 5 years ago, which talks about some of the things we talked about today. And that is available on Audible also. And another one I co-wrote with someone named Eric Rifkin called Interpreting Health Benefits and Risks. And it looks at an easy way to figure out if what your doctor's telling you makes sense or not. And a way you could bring into the doctor's office to really advocate for yourself and for your loved ones. Both of them are on Amazon. I also have a website, which is www.andylazarus.com. And that's where I have a podcast and a blog, and all my books are there, including my crazy fiction books. But the bottom line of that is I do have links to other information there. And because there are a lot of good books that talk about this, and it's really important to get your resources down and to advocate and not, once you think the doctor's the expert, you're going to lose. Once you think you're the expert on your mom or dad, that's when you're going to go and be able to advocate, and you are the expert, and you should not let the doctor intimidate you.
Okay, great information. I'm going to close here, but I do want to just ask everyone, to think about accessing some of those tools and resources. I think this is really good information for families and for older adults who maybe aren't dealing with a dementia diagnosis, but maybe they have other chronic conditions and they find themselves in that same position where they're going back to, multiple doctors, and they're kind of being passed around to different specialists. And that's frustrating for people. And there's a cost associated with it. So, making sure you're getting sort of the right advice, but also you have that right sort of approach to care. You mentioned quality of life and treating the whole person. I would imagine those are things to look out for when you're picking a primary care physician.
Absolutely.
Are there in closing, any questions that you would recommend that folks ask a potential primary care physician if they're kind of between two and can't decide which one they want to go with? What might be some really good questions to ask when they're trying to figure out, is this person coming to my clinical care with this holistic mindset?
Yeah, I mean, the two big ones are how likely are you to send me to a specialist, and also how likely are you to treat my numbers versus me, and that's really the second one's the biggest one, because doctors are trained to treat numbers, and you don't want a primary care doctor doing that.
Okay, great ideas. Well, we so appreciate your time, your expertise, and all of your knowledge. This was really great information for our families. And thanks so much for taking the time to join us today.
Well, thank you very much for having me. Take care.
Thank you. You as well.
All right. Thank you so much, Lynn and Dr. Lazarus. That was an awesome presentation, a lot of really great information that we may not have known before. We'd like to take this opportunity to invite you to become a member of the Enrich Brain Health Program if you're not already. You can sign up on our Enrich website, which is up on the screen right now, enrichvisits.com. And if you're interested in more information from the PCAT Research Center, you can follow us on our social media. We have Facebook, Instagram, Twitter, and LinkedIn. I have those links up for you right now. If anybody has any questions, you can go ahead and enter them into the chat box. I see we had some come through already, and a member of the BCAT team will respond to you within the next 2 to 3 business days via email. Thank you guys all so much for joining this episode of Family Matters. And we hope to see you again for our next episode in May, where we ask the question, how do I know when psychiatric care is needed for older adults with cognitive impairments and or dementia? I'm gonna just stay in the meeting for a couple more minutes in case anybody has any questions. But otherwise, I hope everybody has a great evening.